very good morning, and this is a very, very special subject. And Dr. Shrikant was first retina specialist from UP. He went to Dr. Nagpal's academy, where he learned retina, and I, being his junior, followed him, and a little bit I know about retina through my teachers and Dr. Shrikant.
Thank you, Dr. Kamalji. This will be more of a practical information as far the laser interactive session is concerned, and many practical tips will be given to you which will help you as far as your day-to-day laser work is concerned. The topic is Mastering Laser Comprehensive Ophthalmologists, basically aimed for the comprehensive ophthalmologists who are bound to, because of the increased workload of retina, because diabetic is coming as an epidemic, and we have to treat this. And if medical retina can do a proper laser and other workup of the patients, we are sure to reduce a burden of surgical retina, in fact. Because many places I have surprised that in Sweden, hardly any patient land up into the surgical retina because of the fact that they have formalized that a medical retina people do the workup and do the laser photocoagulation, and if required the intravitreal injections, that many patients who otherwise were landed into proliferative diabetic retinopathies were treated in the before end stages only. Thus, it's a great saving on work hours being lost for the surgical procedures. Retina being a laser being a day-to-day procedure, day-care procedure, so many hours lost due to admission and surgical procedures are being saved. Here, Kamalji, although he has mentioned that I was there, but he is really self-made person, very laborious, very sincere, and he has developed the art of medical retina. Once other people were indulged into surgical retina, he preferred to do the medical retina, and I think he has done lot number of fluorescein angiographies and laser photocoagulation. Initially, he did the Clinitex xenon arc photocoagulator also.
Yes.
Because we were in UP was the first to have the xenon arc photocoagulator by Clinitex, and which was xenon arc photocoagulator. Later on, the laser photocoagulation have come up. So I invite Professor Kamalji Singh, who was a professor and head at RIO, and now he is heading the department of Medical College, United Medical College and Allahabad, and has a vast experience of doing the medical retina work, fluorescein angiography, and yes, initially the Clinitex xenon arc photocoagulator as well. I invite Dr. Professor
Thank you,
Kamalji
sir.
Singh.
Thank you so much. I find there are such young retinal colleagues sitting there who are very well trained. I was trained by myself, and I used to go during summers to RP Center because my sasural is there in Delhi. So I used to stay there in my sasural and used to learn lasers and angiography. There were no fellowships then. Dr. Lalit Verma, Professor H.K. Tiwari, Dinesh Talwar, Dr. S.P. Garg, they were the stalwarts, and whatever little I know of laser is because of these gentlemen. My teacher, Professor R.N. Mishra, was very much interested in having the newer equipment. Those days it was very difficult to get even a microscope, and even slit lamps were not available to the residents or even consultants. It used to lie in the head of the department's room, and nobody was allowed to check. Uska cover bhi nahi utarta tha kai baar. So at that time he could think of having fluorescein angiography and then lasers. It was really marvelous, and we initially अभिषेक 5 मिनट में बात 5 मिनट में बात करते हैं. तो initially we had a fundus camera. Zeiss fundus camera was there, which was given by the government of India to all the medical colleges, and it was lying almost waste in the medical college. Then when I became medical officer, he said that why don't you start doing this? And I was knowing nothing about angiography. So those days उसमें रील लगती थी, रील लगा के फिर नेगेटिव्स बनते थे. नेगेटिव्स में हम लोग उसमें जैसे स्क्रीन में एक्सरे देखते हैं वैसे देखते थे. और ये कंप्यूटर फ्रेंडली एंजियोग्राफी वाज नॉट देयर. So when I used to see them, the fundus examination was done by direct and indirect ophthalmoscope. Whatever the examinee used to tell कि ये है तो वही final हो जाता था. There were no photographs available. And first time when I presented photographs of fundus in a conference in Kanpur, they said that किसी किताब से चुराया है तुमने. They couldn't believe that you can take the fundus pictures in a medical college. So all photographs were from the. So Professor Anand Mishra, he said that you will start doing fundus camera, and gradually we in the year 1992 the first laser came. And उसमें भी जो लेज़र होता था बेसिक्स इसलिए बता रहे हैं बिकॉज यू शुड नो द डेवलपमेंट. देयर वाज एक कूलिंग मशीन होती थी, पानी से वो आता था. उसके बाद वो जब आप लेज़र बर्न देते, जैसे पुराने ज़माने में एम्बेसडर कार होती थी, तो उसमें से जो जब आप स्टार्ट करते थे तो 10 किलोमीटर के बाद एक जूनियर आदमी बैठा होता था जो पानी डालता था उसमें, तब फिर आगे बढ़ती थी. तो उसी तरह का वो लेज़र था, बड़ा सा एक वाटर कूलेंट रखा हुआ था और इधर ऐसा लगता था कि किसी मैकेनिक की शॉप में आ गए. और सिमिलरली जिनॉन आर्क, एज डॉक्टर श्रीकांत वाज सेइंग, इट वाज हाई इंटेंसिटी बर्न्स 1000 माइक्रोन के करीब लग जाते थे और इतनी ज़्यादा इंटेंसिटी होती थी कि रेटिना पूरी तरह से बर्न कर देता था. नॉट ओनली द रेटिनल पिगमेंट एपिथेलियम वेयर दैट इज़ वेयर वी normally target when we do laser photocoagulation. So gradually we improved, and so I am thankful to these teachers. Laser, as I don't need to tell you all that it's the full form. We were not even knowing the full form then. So my basic questions used to be from MBBS and postgraduates कि लेज़र का फुल फॉर्म तो बता दे यार. जैसे लेसिक आया, लेज़र आया, PRK आया और इतने आ गए, RK PRK सब कुछ आया वैसे ही. So it's light amplification by stimulated emission. What does this mean? This means that all the electrons, they keep on revolving around orbits. So when we put in a like argon laser की गैस है, जब लेज़र डालते हैं उस पर तो वो स्टिमुलेट होता है and that it jumps into the next orbit. तो जब ऑर्बिट में जाता है तो उसमें एनर्जी पैदा होती है, and then what happens that this energy that liberates, when it comes back, this electron comes back into the original orbit, then that energy is liberated and that energy goes as laser. So this laser can be transported from here to moon without any problem. All these white lights that we see, the visible spectrum that we see, this cannot go beyond miles. Whereas laser light, if you put here, it can go up to moon without any problem. It will not deviate. So there are certain qualities of laser photocoagulation that it remains columnated, एक direction में जाते हैं, and they can travel to any distance. And we all know that these days lasers are being used in wars also. यहाँ से target करते हैं, दूसरे country में जाके मार के चले आते हैं. Similarly, we can hit the retinal pigment epithelium without any problem. You can cross the cornea, you can cross the lens without damaging them. You can hit the target and you can get the effect of the laser photocoagulation. So this was there. And how does it works? It works on the principle that it is absorbed by the pigments. Like melanin होगा तो वो उसमें absorb हो जाएगा, hemoglobin होगा तो उसमें absorb हो जाएगा, xanthophyll के जितने भी हैं. So all these pigments, retinal pigment epithelium, because there is a lot of melanin, so it usually goes there and it's there. जो xenon arc होता था, whereas it used to burn the whole retina and choroid, all layers were burned, so the damage was too much. So this is what we get, and the effect we will discuss later. So as I have told you that there can be gases, there can be crystals, and there can be liquids and diodes. तो पहले जो गैसेस आती थी वो थोड़े दिनों में वो मशीन ख़राब हो जाती थी, वो गैसेस का कुछ दिनों में निकलना बंद हो जाता था, और तब यूज़ टू बी वेरी एक्सपेंसिव फॉर अ इंडिविजुअल एंड इवन फॉर इंस्टीट्यूशन टू बाई अ लेज़र मशीन. So gradually when diode came, their life became longer, and now we can have, like I have a laser photocoagulation. In the year 1998 I bought this Iridix machine. It is still working. So उसमें अब छोटा सा कंसोल आ गया हमारे यहाँ, पहले वहाँ से लेके यहाँ तक एक कमरा था लेज़र मशीन के लिए. So that sort of situation has occurred now, and now depending on this, its usage is different. Like if you look at this spectrum, and the wavelength is starting from 400 to 700. This is the visible spectrum. So beyond this is called infrared, and below this wavelength is called ultraviolet, which you all know can be used for corneal purposes, and infrared is used for, like carbon dioxide and other lasers are used for removing the growths, carbon dioxide laser and all that. Our job is here to, we had blue-green wavelength laser, 488 and 514 wavelength के आते थे blue green, और अलग अलग situation में we used to use this laser photocoagulation differently in our patients. तो blue कहाँ use करना है, green कहाँ use करना है, ये seniors बता दें या आप पढ़ लीजिए, and then you used to, green was considered the best for doing the laser in retinal photocoagulation. So then came the double frequency YAG laser, which is you all know 532 laser, which is being used these days quite regularly by all, and for retinal purposes mainly. And as it is mentioned that these are various wavelengths that are being used for laser photocoagulation. Rest of the indications that we have for laser photocoagulation, we all know. Commonly we get lots of cases of diabetic retinopathy where in a single day I used to do, in dozens of patients I used to get tired, and nobody used to enter into that room because वो जानते नहीं थे क्या लाइट वाइट हरी नीली पीली मारते रहते हैं और कितना गलत करते हैं कितना सही करते हैं, ये हमें भी नहीं मालूम था, उन्हें भी नहीं मालूम था. So that sort of situation was there then, and PRP वाले ही मरीज आते हैं ज़्यादातर, which means pan retinal photocoagulation, and grid होती थी, and प्रोफेसर ठाकुर साहब होते थे. तो वो जब हमें मिले तो उन्होंने नाम हमारा ग्रिड रख दिया था कि ग्रिड आया है ग्रिड आया है. तो ग्रिड था which was macular photocoagulation, and then scatter photocoagulation, which means that a quadrant is affected, like in BRVO we do scatter photocoagulation or scatter in, when done in all the 4 quadrants, we call it pan retinal photocoagulation. With 200 micron size you have to give 1500 to 2000 burns. In a neovascular glaucoma patient you need further laser photocoagulation. When you do laser photocoagulation, take care that you don't hit the vessels, go into the retina where you can see the retina, and don't touch the blood also. So you have to simply burn the retina with the laser photocoagulation and 200 micron shots in the central area, leaving this macular arcade that is there for PRP. For grid then you decide depending on that. For grid, what you do is you simply give 1500 to 100 micron size, light white intensity burns, whereas in pan retinal photocoagulation you give white intensity burns. Quite remarkable white intensity burns are given, and 1 space apart is the usual thing that is told. So these are some of the basics that I wanted to discuss. So diabetic retinopathy, BRVO, Eels disease has become less common these days. In our time, Eels disease was quite common, and we used to do lots of laser those days for Eels disease also. Then CRVO, then further glaucoma, and all those things have come for glaucoma. So these are some of the basic I wanted to discuss with you all, and then thank you so much.
Thank you, Dr. Kamalji, for giving a brief history about the evolution of the lasers. And then say one interesting point I want to mention, because now many semiconductor lasers are there. I was involved with the initial studies by Carmen A. Puliafito at Retina Shades, Boston. He was working with Massachusetts Institute of Technology. He developed these lasers with being a portable, doesn't require any cooling systems, only a fan can serve the purpose. But initially it was a very shock to the Carmen Puliafito, because infrared, it was infrared, which was invisible light, and 80% of it was absorbed by the choroid. So they said that it is not the laser to be used for the retina initially. But then further research work was done. They found that 80% of the laser which was absorbed by choroid, 50% of that is given back to the retina. So it has become applicable to the retina as well, because 20% is absorbed by the retina, but 80% was absorbed by the retina, but 50% of that was given back to this. And now semiconductor laser is a portable type of laser, doesn't require any water cooling, even air cooling is not required, and it is available into a higher wattage also, so one can serve the purpose. So I just wanted to mention that some new discoveries comes, but fallback, but if they do work on the details, they can come to the conclusion, yes, further improvement can give you a justifiable answer to the disease process.
Yes, sir.
With this
The Pascal
Yes.
काम you can give shots very easily. Does not take much time. एक बार में आपने
Yes,
सवा
एक
सौ
बार में
shots
डाल
एक
के
जगह
आप-
लगाया.
yes.
Scatter. I couldn't
I
show
think we have
that
got a
because
topic
paucity
also
of
who
time.
it will be covered by some of the speakers on
Okay.
Pascal. Professor Kamalji is rightly mentioned, because suppose you have got a 50 laser, it is very difficult. One very do is doing 1500 shots. Simultaneously 500 shots can be given in one go, and thus in a 3 or 4 sittings, 4 shot itself it can be done. Now we call upon Pranav Sujuya. It is बैठा तेरे बारे में बता दूं जरा. Pranav Sujuya is a son of Professor Kamalji Singh. He is trained at SadguruNej Chikitsalaya in a vitreoretinal surgeries and medical retina. His field of work now he is a practicing ophthalmologist with a vitreoretinal background. He is doing more of a ROP and vitreoretinal surgeries and taking care of cataract as well, and taking care of Banaras as well. He is coming to Banaras as far as the question is concerned. But yes, he is doing that. I call upon Dr. Pramana Saluja. He'll be talking on BRO studies and protocols. Welcome, doctor.
Hello. Thank you so much, sir. So on behalf of AIOS, I would like to thank for providing me this opportunity, and Dr. Kamaljeet Singh and Professor Shrikant sir also. So we'll be talking about BRVO studies and protocols. Mainly the prevalence of BRVO is around 4.42 per 1000, and BRVO can be further classified as a major BRVO, which is an occlusion of a retinal vein that drains directly to one of the quadrants, or a macular BRVO, which is an occlusion of a venule within the macula. So in BRVO, usually the obstruction occurs at the AV crossing, and this is a typical site for branch retinal vein occlusion. The main causes of vision loss in BRVO is macular edema, and as we can see in this OCT, there are multiple cystic spaces and inferior, and we can also know according to the OCT also that what type of retinal vein occlusion is present. And the other causes of vision loss is usually intraretinal hemorrhages. This is a fundus fluorescein angiography which shows masking due to the intraretinal hemorrhages. Then there is ischemia and neovascularization which can occur, and this is what we usually treat with the help of lasers. And if there is superior ischemia, then usually a sectoral laser is done. And if there is neovascularization, especially in this case, like there is neovascularization of the disc and multiple capillary non-perfusion areas can be seen in the superior quadrant. So in these cases, we can go for a laser photocoagulation. This is another case which is a fundus fluorescein angiography. This has large capillary non-perfusion areas, but there is no neovascularization. So in these cases, usually we can observe if the patient is good and comes regularly on follow-up. But if the patient is not coming on follow-up, we can laser in these cases also. So as we talked about, it can be ischemic or non-ischemic. In cases where there is ischemia and neovascularization is present, in those cases, especially we have to laser. Then there is another thing which is known as macular ischemia, and we can see that in this fundus fluorescein angiography, there are the FAZ is distorted, which is the foveal avascular zone. It is enlarged, and this signifies macular ischemia. And in these cases, usually grid laser is usually contraindicated. So now coming on to the studies, there were two. The landmark trial was the branch retinal vein occlusion study, which suggested that greater than 5 disc diameters of non-perfusion areas has a significant chances of development of neovascularization, and in these cases they signified that it is better to laser. But in Vibrant, this was a recent study. They suggested that there is if there is greater than 10 disc areas then of non-perfusion, then in these cases there are higher chances of development of neovascularization. So as we've already talked about, if there is arteriosclerosis and AV crossing of the retinal branch vessels play important role. And at AV crossings, usually where the thick-walled arteries are present, it compresses and obstructs adjacent thin-walled veins. And this follows the virtuous triad. There is hypercoagulable state, there is stasis, and then thrombosis, which leads to vein occlusion. So again, neovascularization is the one that usually we have to treat with scatter laser. And then in long standing sequelae, there is chances of development of vitreous hemorrhage. So what does the treatment usually focus on? It is mainly to reduce the macular edema, preventing neovascularization and treating the neovascularization to reduce the risk of vitreous hemorrhage. Usually to treat macular edema these days, because of the development of anti-VEGF, we usually start the patients with anti-VEGF. Coming on to BWAS, they set out to answer 3 questions. So the first question was that can scatter laser photocoagulation prevent the development of neovascularization? And the other was that whether it can prevent vitreous hemorrhage following the retinal neovascularization. And the third was whether macular grade laser photocoagulation improves the macular edema. So it was a multi-center prospective randomized controlled trial, and they found out that the treated eyes were more likely to gain visual acuity, which is around 65% in comparison to 37%. And also they recommended that once neovascularization develops, at that point the scatter laser should be done. So again, the visual outcome, as we can see, with laser treatment was better and less than 20/40 in 60% of the patient, while without treatment it was less, which was around 34%. So the other trial was the SCORE trial, which was another landmark trial, and it was also a multi-center prospective randomized control trial. They compared 1 mg and 4 mg triamcinolone acetate intravitreal injections with grid laser pattern, and there was no significant differences which were found in this study. And the other thing was that the corticosteroid treatment, as we all know, features a worse side effect profile, which is like the IOP increased more in these cases, and also there were higher chances of development of cataract. So the indications of sectoral scatter photocoagulation is usually to treat the ischemic complications, which is neovascularization, and also in cases where there is neovascularization in on the iris or the angle. So it mainly reduces the oxygen demand by destroying the photoreceptors within the retina. The hypoxia is corrected and production of cytokines is normalized. And the hypoxic areas are mainly converted into anoxic areas, so that there is lesser release of VEGF, and this prevents the development of neovascularization. So in PWAS outcomes also, they found out that scatter laser photocoagulation prevented the development of neovascularization and also vitreous hemorrhage in cases where there was neovascularization already. So what are the parameters that we usually use? They are usually around 200 to 500 micron size. 0.1 to 0.2 second duration is usually given, and medium white burns are given. This will be covered later on also. And other thing is that the laser spot should be applied over the areas of the ischemic areas, and especially a good fundus fluorescein angiography should be done to delineate the capillary non-perfusion areas and to laser it accordingly. Usually a 1 burn apart width is what we consider. The complications that can occur is usually choroidal hemorrhage, premacular membrane can develop, which is an epiretinal membrane. In the long-term sequelae, there can be an accidental burn to the fovea. In cases where there is extensive laser done, macular edema can develop. There can be also, if a very high power of laser is given, there can be chances of hemorrhage after Bruch's membrane rupture. Then again, extensive laser can cause choroidal effusion also in lots of cases, and visual field effects is one of the problem, and also night vision problems. So the follow-up should be usually every 3 to 4 months in these cases, and as we've already talked about, after 3 months, usually a fluorescein angiography is must. And if neovascularization persists, then usually scatter laser may be added. And another thing which is very important is to do a good gonioscopy every 3 to 4 months to look for subtle signs of neovascularization. So again, CWAS said that prophylactic PRP did not prevent any neovascularization. So only in the active neovascular disease, they suggested lasering until or unless the patient is not able to come to your follow-up and you know that the patient is not very compliant. So the indications of macular grade laser is usually the duration if there is persistent macular edema and the visual acuity is less than 6/12 without significant macular hemorrhage, then in these cases usually we should do. The most important thing to note here is that the FFA should show a good capillary perfusion. Otherwise it is not good to laser in grid laser. Then what is the mechanism? It is mainly, it improves the tight junctions of the RP, and this was demonstrated by BWAS also. The technique will be demonstrated later on. And again, BWAS depicted a significant improvement in the visual acuity with grid laser. The recent studies which have been done are the Brighter and the Retain studies. They added laser to ranibizumab to see whether there is chances of decrease in the amount of anti-VEGF, although in their study they did not improve outcomes, but in our practice we usually laser in cases where there is persistent macular edema, and the amount of anti-VEGF that we have to give is usually lowered in these cases. So grid laser is limited now to when frequent follow-up is difficult, as we've already talked about. And there was another study which was the RELATE study, which tried to find out whether scatter laser to the peripheral ischemic areas will decrease macular edema, although they also did not find out anything significant. So again, the contraindications as we talked about, that the macular perfusion should be checked, and if there is macular ischemia, then we should not do a grid laser. Thank you. I'll just keep it short because the time is over. Thank you.
Thank you.
It's a wonderful talk by Dr. Pranav Saluja. May I invite Dr. Smriti for her presentation on central retinal vein occlusion. इंट्रोडक्शन आप बहू का इंट्रोडक्शन देना जरा मुश्किल है.
She is the daughter-in-law of Professor Kamaljeet Singh. She is trained from Sadhguru Ney Chikitsalaya in medical and surgical retina. She is main interest of vitreoretinal surgery is especially the ROP. She is doing much work, in fact, if I am not wrong. I invite Dr. Smith Galan. Please carry on, please. Thank you.
Very good morning to all. It's an absolute pleasure to be here, and on behalf of AIOS, I would like to thank Dr. Shrikant sir and Dr. Kamaljeet sir for giving me this opportunity to present here. And today my topic is CRVO studies and protocol. So we know that we classify the retinal vein occlusion mainly into central retinal vein occlusion, central retinal vein occlusion, and branch retinal vein occlusion. And also clinically, CRVO is classified distinctly into two types. One is non-ischemic CRVO and one is ischemic CRVO. Coming to the incidence of CRVO, so non-ischemic CRVO, which is less severe, so this is the most common form of CRVO, around 80%, and 20% of them is the ischemic CRVO. About the pathogenesis of the central retinal vein occlusion, so we know that there is a thrombosis of central retinal vein at the lamina cribrosa that happens, which leads to the central retinal vein occlusions. And the various risk factors which are involved in the CRVO are the age, hypertension, diabetes mellitus, glaucoma, any hypercoagulable state, any medications like oral contraceptive pills or diuretics. These are the common risk factors. Coming to the features of non-ischemic CRVO versus ischemic CRVO, the non-ischemic CRVO can cause chronic macular edema, it can cause central scotoma, it can convert into ischemic CRVO, or it can further leads to, if the cilioretinal artery is present, it can lead to cilioretinal artery occlusion, and usually there is no ocular neovascularization present in the non-ischemic form. Coming to the ischemic CRVO, it leads to the neovascularization of the anterior segment. It can cause neovascular glaucoma. There are chances of vitreous hemorrhages, and it can also lead to optic nerve atrophy. So the conversion rate of non-ischemic CRVO to ischemic CRVO, it has been studied that if the age is around 45 to 64 years, the conversion rate is around 8% with 18 months of follow-up. And same, if the age is more than 65 years of rate, there is a higher conversion rate, which is around 18%. So basically, the age, if more than 65 years, there are higher chances of conversion of non-ischemic CRVO to ischemic CRVO. Coming to the management, the most important part to determine in the management is first to differentiate between ischemic CRVO from non-ischemic CRVO, because that totally changes our management and the prognosis also totally changes. So the first step is to basically differentiate between the ischemic and non-ischemic CRVO. So there are various comprehensive eye assessment that we do in the CRVO cases. So we do the morphological test and we do the functional test. So in the functional test, we do the visual acuity, we do the pupillary defect (RAPD). We also do the electroretinography, we do the visual fields. And coming to the morphological test, we do the ophthalmoscopy and angiography. Among them, the most reliable is the electroretinography, but electroretinography, if it is combined with the RAPD, it is most reliable among all these tests. And the least reliable is the clinically, that we do the ophthalmoscopy. So coming to the treatment, so we do basically, we can do the medical treatment, we can do the photocoagulation therapy, or we can go for a surgical treatment. So there are various clinical trials which, so there was an evolution of CRVO treatment strategies. So we started in 1995 with the laser therapy, which was told by CWAS trial. And and then now we have anti-VEGF, and now we also have the comparative between the different anti-VEGFs. Coming to the fourth study, which is the CWAS study, it was a multi-center randomized prospective control study. There was two questions that they have asked. One is can photocoagulation decrease the neovascularization? And the second question was does macular grid pattern decreases the vision loss from macular edema? Also, they did not do any intervention. They just followed the natural history of the patients. So the findings from the CWAS studies showed that there was a reduction of macular edema with macular grid laser, but there was no improvement in the visual acuity. Also, they have told that early PRP failed to reduce the risk of neovascularization of the iris. So macular, also they have said that the macular grid tend towards better visual acuity in the younger patients, and there was no improvement in the older patients, but it was clinically a non-significance. So the laser recommendation from CWAS that we got was treat neovascularization only after it develops and initiate PRP only once 2 clock hours of neovascularization have developed. Also, they have said that no laser is recommended for macular edema in CRVO. Coming to the second study, which is the SCORE study, which was based on the triamcinolone. They have done the standard care versus corticosteroid for retinal vein occlusion. So what they have done is they took the standard versus 1 mg IVT versus 4 mg IVT. Total number of patients was around 271, and their endpoint was percentage that gained 3 lines or more at 12 months, and they followed the patient for 36 months. So what CRVO studies have told that if we give 1 mg IVTA versus 4 mg IVTA, 1 mg group was almost 1 mg and 4 mg both have around 26% gain in 15 letters, whereas the observation group have only 7% gain letters. So what they have recommended is 1 mg IVT is better than observation. One more study on the steroid was the Ozudex, that is the Geneva study. In the Geneva study, they randomized the patient to 0.7 mg or 2.3 mg versus sham. So after 6 months, they have said that 0.3 mg or 0.7 mg both have around 41% gain in 15 letters in both the groups versus only 23% here in the sham group. Also, only the 3 patients needed glaucoma surgery in 0.7 mg group, whereas 30% required IOP medication. So IOP spike with Olurex occurred usually around 8 weeks, whereas the IOP spike with IVT around 34 days after injections. Then we come to the anti-VEGF, which is now the standard of care. One of the studies, the CRUISE study, where it was they have done the randomizumab 0.3 versus 0.5 versus observation. And their endpoint was the change for BCVA at baseline at 6 months. But they have said that 46 and 47% gain in 15 letters or more compared to 17% in sham group. Also, what they have said that the treated group gained an average of around 12.7 and 14.9 letters compared to the 0.8 0.8 letters in the sham group. Another study, so the Cruise study said that anti-VEGF is now the treatment of choice, standard of care in the retinal vein occlusion, and the drawback was that there was we have to do the repeated injections, and also after stopping the anti-VEGF, they can still develop the neovascularization. One more study on anti-VEGF was the Galileo and Copernicus study. They have studied the intravitreal aflibercept 2 mg versus sham, and they have followed the patient till 6 months, and then further on PRP basis from 6 to 12 months in both the groups. And what they have said that there was an increase in around 50 to 60% gain 15 letters in the aflibercept group versus the sham group. Then there was one more study, which is the SCORE2 study. Now they have compared the effectiveness between the two bevacizumab and aflibercept group. So two anti-VEGF agents, bevacizumab 1.25 mg versus aflibercept 2 mg. They have injected the patient every 4 weeks, and the 6 months prior primary outcome was followed up, and visits ongoing through 5 years. So what they have concluded that conclusion was intravitreal bevacizumab was non-inferior to aflibercept with respect to visual acuity after 6 months of treatment. So we can also use the bevacizumab as an alternative because it is cost effective also. So this is that study has told. Compared to a new study which just happened in 2023, which is one faricimab. It was a Comino study. It was a phase 3 double mask clinical trial. What they have studied is the safety and efficacy of faricimab in comparison to aflibercept patient with macular edema secondary to CRVO. They have what they have tell that 20 to 25% patients in each at 24 weeks in both the treatment arm, rapid vision gain and central retinal thickness with faricimab was non-inferior as compared to aflibercept. Also, they have said that there was in both the arms there was 20 to 25% of ocular adverse event were present, which was mild to moderate in severity. So overall, faricimab was well tolerated. Safety profile was comparable to aflibercept. So my take-home message was that perform PRP only after neovascularization develops and avoid lasers in the macular edema. We can use a 1 mg IVTA for CRVO macular edema. Dexamethasone implant can also be used to improve the vision, but we have to monitor the IOP. Also, anti-VEGF is now the standard of care, and there are various ongoing treatment which still going on the studies. And the recent study on faricimab trial has showed that there's a comparable efficacy of aflibercept for reducing the macular edema in CRVO. So these are my references. Thank you.
Thank you, doctor.
Thank you.
Now I invite Professor Shrikant.
नहीं, तन्वी जाना है बेटा?
अच्छा, पहले तो जाने?
जाए?
अच्छा. So, Dr. Tanvi Jain.
Yeah, please.
Good morning, everyone. I would like to thank
Dr.
Shrikant.
Tanvi is from Chitrakoot again, and she's working in Mumbai at AIOS2025 hospital. Dr. Tanvi, please.
So I would like to thank Dr. Shrikant and Dr. Kamaljeet sir for this opportunity. So today I'll be talking about focal and grid laser. So if we talk about focal laser basically targets on a focal lesion like microaneurysms, some intra-retinal microvascular anomalies, yeah, capillary leakage, focal leakages. So it is intended to directly seal the leaking vessels. And when we talk about grid laser photocoagulation, so it is performed in the non-center involving areas of macular thickening with diffuse leakages or some areas of capillary losses. So the burn are spaced one burn apart in a grid pattern laser. The end point of the burn should be just grayish. When the burn turns grayish, that is moderate burns. We should avoid foveal avascular zone while lasering during grid laser photocoagulation. So this is just a graphical presentation. As you can, my pointer is not visible, sorry. So in the first picture, we can see that those black dots represent the focal laser, and here is the grid pattern laser. So, if we talk about the indication and clinical application, the focal laser usually done in DME, and we laser the microaneurysms in diabetic macular edema. And in grid laser, we do laser in diffuse macular thickness, but obviously more than we avoid lasering FAZ. So other uses are also there, like BRVO and some CSCR which have point leakages, and also selected cases of retinal vascular anomalies like hemangiomas. So when we talk about mechanism, actually it has been very well explained by Dr. Kamaljeet sir, but still there are two effects. One is thermal effect, another is secondary effect. So thermal effect, when we talk about, the heat does protein coagulation, which directly seals the leaking vessel. And when we talk about secondary effect, so secondary effect may it basically work on RP pump function, and cytokinins are released, which eventually reduces the VEGF production, which leads to retinal tissue remodeling. So laser parameters, although it has been told by Pranav, but I'll be just going through it. So when in focal laser, the spots are little smaller compared to grid laser. In focal laser, we just do the blanching. So the duration of the laser is 0.05 second to 1 second. Power is titrated in such a way in focal laser that there should be only blanching. We do the delivery in both the laser system by slit lamp photocoagulation using contact lenses, and laser is used, green laser with frequency of 532 nanometers. So when we plan the treatment, we have to do few investigation like fluorescein angiography to just locate the leakages point. During diffuse or grid laser, we just do OCT to just locate the retinal thickening. So clinical outcome and benefits, it is obviously durable, it is very durable and anatomical effects. As per ETDRS and some other studies also, it has been shown that it reduces the moderate vision loss by 50%, and obviously it is very economical. And it has been seen that eye after focal or grid laser keeps improving even without any additional treatment. Laser remains the effective treatment in non-center involving DME. So what are the advantages? It is obviously a long-lasting effect compared to the transient effect of anti-VEGF, lower cost, and when it is combined with anti-VEGF, can reduce the injection frequency as well. There are potential complications as well. Sometimes if the laser are not done properly, so expansion of laser scars can be there. There can be development of some central scotomas. Night vision issues can be there, and rare instances of coronary vascularization has been seen. So we can mitigate these issues by just using modified lower intensity laser burn. So to conclude, focal and grid laser are proven techniques for managing DME and other retinal vascular issues, but it requires precise techniques and patient selection. Laser continue to have a vital role even in era of anti-VEGF. Role has evolved but not disappeared with anti-VEGF. These are my references. Thank you.
This BRV, as you all know, we have already discussed scatter photocoagulation and grid photocoagulation, and Dr. Jan has done a wonderful job.
Thank you so much.
And so thank you so much, Dr. Tanvi. May I request now Professor Shrikant to please deliver his talk.
Follow-up is also equally important. Follow-up means not as if you have done the laser and patient is okay. She has mentioned that even if you have not done the laser again, then patient will still continue to improve upon. But then also we have to look into the various parameters to follow up these patients, which is very important. Not as if the end of the game, by doing just a laser photocoagulation, you have finished the case. The follow-up should be included as per the history and examination. That means the duration of diabetes, a perfect control, that be HbA1c, fasting blood sugar. Diastolic blood pressure is also very important than the systolic blood pressure. Lipid profile. Any neuropathy or nephropathy is developing alongside this, because diabetes, if suppose patient is suffering with diabetes, diabetes can cause the nephropathy and neuropathy also, so you must look into that also. Medication, especially the insulin, oral hypoglycemic, antihypertensive, lipid lowering drugs are also important to consider. Follow-up history as examination is concerned. Hello, ये change क्यों नहीं हो रहा बेटा? हाँ, ठीक. The visual acuity is also important. Then measuring of IOP, slit lamp microscopy. As we are in habit of doing fundus evaluation mostly by doing the indirect ophthalmoscope, we dilate the pupil. But if you are suspecting the neovascular glaucoma or neovascular angle glaucoma, then you must do undilated pupil gonioscopy, because dilated pupil results will not be there, because overcrowding of iris will not let you know into insight of the angle of anterior chamber. So undilated pupil examination is important. One can use the small pupil or Skipin's Pomerantzoff. There is a very good interesting history. I must recollect that how the things evolved. The small pupil was not developed by, it's as per the nomenclature, but it was a Skipin's Pomerantzoff. Pomerantzoff was a physicist with Skipin's in retina sheets, and he was a high myopic physicist. So once Skipin's wanted to examine his fundus, so he could not bear the light. If you have got yourself examined by indirect ophthalmoscopy, it is very difficult. The bright light doesn't permit a high myop to be examined by indirect ophthalmoscope. So he went into indulged into the process of developing a indirect ophthalmoscope, wherein without dilating the pupil, you can examine this. So it was a principle which was given by the Pomerantzoff, who himself was a physicist working with retina sheet in Skipin's, Boston. And thus Skipin's Pomerantzoff indirect ophthalmoscope has come, which doesn't require any dilatation of the pupil. You can examine the fundus without dilating it. So it is important in case if you are looking for a post laser patients, especially the angle, without dilating, you can use the small pupil indirect ophthalmoscope and can examine the fundus, and then simultaneously can do the gonioscopy. As I have already mentioned, non-mediatic fundus cameras are also available. Indirect ophthalmoscopy, non-contact biconvex lens, because that gives you a stereoscopic three-dimensional view. You can very well evaluate this. And the gold standard was initially in our time was a 3-mirror Goldman mirror, by which you can examine from anterior to posterior, and magnification was much higher than compared to the 78 to 90 D. You must look, once you are examining these things, you must look for the iatrogenic hemorrhages, vitreous hemorrhages. Monitoring of intraocular pressure is very important, because many times patients after lasers can develop the higher this, and you may lose the patient by glaucoma, because of the glaucoma. And record keeping is utmost important. Utmost important, that give you an idea how the patient is faring and how many times you have done the laser or so. Previously, we were just putting up the scar as far the retina is concerned. I'll just let you know. The record keeping is very important. You must record whatever the laser you have done. Not only the record the laser which you have done, but in case of ROP screening patients or ROP where you have done the laser, you must put the record, because patient will not tell you. It's all your record which will tell you how the patient is faring as far the ROP is concerned. And number of laser sittings are all important. Previously, we were just mixing up a cross, just the laser is done. Now we are putting up a cross. As far the sitting point is concerned, you can put up your mnemonics or your nomenclature. You can put up a alpha, beta, gamma, theta, and epsilon. So the patient will not know that where the laser is done, but you know that it is alpha, beta, theta. So that is very important, that because patient will require many sittings of the laser photocoagulation. You must know in where you did the first sitting, where you did the second sitting, where you did the last sitting. एक मिनट बेटा. And if facilities persist, you must do the fundus photography. Fluorescein angiography, yes, nowadays we are not doing it because the advent of OCT angio also, and being an invasive procedure, not many patients are done. But yes, initial footage or details of retina photocoagulations were based on a fluorescein angiography, ischemic and non-ischemic version. In high resource city, you can do optical OCT also to keep the records. OCT angio I have already mentioned, there's a new development is there, although many things are required to be done further on this development is concerned. Even the older versions of OCT can have a upgradation of OCT angio, which is not that superior as the coming OCT angio is coming, but you can improvise the existing OCTs by adopting a software which can develop it to near OCT angio instead of buying a newer device. That's the important message. Laser is not a one way, one shot. You require many umpteen times of evaluation of your patients, and so one sitting laser is not the end of the game. So that's very important message which I have given in a joking way, but this is correct versions, because these patients require regular follow-up at a regular interval so that you can treat them perfectly and they can restore the workable visions. Otherwise, many patients who are landed into problems because they once up, like a patient ने cataract कराया तो अब तो दिखना ही है जिंदगी भर. It's not so in laser. Cataract laser is different. Laser you require a perseverance, patience, and patient has to come to a umpteen number of follow-ups in fact. Perfect control of diabetes if diabetes is the cause, perfect control of hypertension if hypertension is the cause. As far the evaluation is concerned, the laser treatment is evaluated 2 weeks after the retinal photocoagulation, a constant follow-up first in 1 to 2 weeks, then after 3 to 6 months, and preferably and then annually. Additional laser photocoagulation performed in cases of new degenerative or a progressive complicated cases of retinal lesions. Things to look after the laser photocoagulations are maculopathy, because if you have done the excessive burns, the maybe macular edema may come up, formation of macular epiretinal membrane, and sometimes iatrogenic retinal detachments also because of the rhegmatogenous retinal detachment. Exudative detachments because of the higher frequency. If I am not mistaken, Kamalji has presented a paper where the Diamox helps as far as reducing this. And then I have gone into the literature. Yes, there was a paper published by the Alan C. Bird from Moorfield Eye Hospitals. He accidentally used Diamox in a case of a glaucoma who was suffering with a diabetic retinopathy. Then edema subsided. Then Alan Bird, with collaboration with Donald Gass, who was a pathologist, formulated that yes, Diamox or acetazolamide helps in reducing the blood aqueous barriers, thus reducing the edema and thus helping in the cases of diabetic retinopathy indirectly. A case of glaucoma which was given a Diamox for glaucoma improved macular edema because of acetazolamide. The dose is not the same 6 to 8 hourly, it's only twice a day 250 milligram. So in some cases where edema persists, you can give a Diamox, this is anti-glaucoma drug, to reduce the edema, and thus once the edema subsided, you can further go for a photocoagulations. I just mentioned that sometimes during the lasers, new vessels may bleed and then can lead to intraretinal hemorrhage, vitreous hemorrhage, and choroidal effusion if excess is there. Rare complications, as Pranav has also mentioned and Dr. Kamalji has also mentioned, because previously we were not understanding the techniques. A incorrect laser photocoagulation can cause the corneal burn, because otherwise laser beams goes directly to the retina. But if it is not improperly focused, it can cause raised IOP, pre-retinal subretinal fibrosis, sometimes the lens opacification can also. They are because of the incorrect focusing in fact, because many times patient moves his hand or head, or sometimes you are not properly aligning it. some of the late complications are impaired color vision, macular peripheral scotoma, visual field loss, and reduced night vision. Alarming symptoms are increase in flashes, floaters, pain, redness, significant decrease in vision, sensation that field of vision is obscured, black curtain. That's very important. Serious adverse effects of laser photocoagulation are uncommon, but excessive laser photocoagulation power, inadequate, incomplete treatment, lack of retinopexy along their anterior margin, obviously excessive large retinal areas. Precautions. I'll just skip. Subretinal vitreous hemorrhage is there. Vitrectomy, if vitreous is not resolving, then you can perform the vitrectomy within a month's times. And if retinal detachment is there, either do the lasers around the tear, or if required, a conventional retinal detachment surgeries. If new vascularizations are coming, an additional laser photocoagulation is required to be done. Retreatment interval should be between 3 months. Thank you.
Thank you so much, sir, Professor Shrikant. Very nicely discussed about the follow-up of the patients who have undergone laser photocoagulation. May I request Dr. Divya to please come over and tell us about the preventive aspects of laser photocoagulation. In all cases where you are doing follow-up, you must keep on looking at the iris also, so that if the neovascularization of iris takes place, then you immediately take the steps to see that it goes back. So anti-VEGFs can be given in those cases. Dr. Divya, please.
Hello. So very good morning. Thank you to Kamaljeet sir and Shrikant sir and Pranav for making me part of this wonderful IC. And I'll be talking more about barrage laser, and I feel when it comes to lasers, injections, there are still misconceptions in ophthalmologists, physicians. I recently had a patient whom I had done a barrage laser. He was a 10-12-year-old child, lattice with holes. He had gone to his physician and he had said that अभी क्यों लेज़र करा लिया, वो तो 18 साल के बाद में होता है. So we need to work on these things. Why we need to know about these lasers? Because we don't want our patient to land up in a condition like this because we missed something like this. So it's very important to identify these conditions, where we have to laser, where we can afford not to laser and keep the patient in follow-up. This is a wonderful article in IGO by Dr. Ramesh Venkatesh and team about screening for these cases. This is more specific to when it comes to refractive surgery and other surgeries. So retinal detachment, all of us know, is a common entity. Around 1 in 10,000 people have it. There are a lot of factors when it comes to predisposing it. One of them being axial myopia, a very important factor. Another being cataract surgery, trauma, and of course the things that we'll be talking a bit about, that is the peripheral retinal degenerations. So I'll not go into the complexities and the pathologies of these. These are quite boring, but we'll just understand some important of these degenerations. Most commonly that we see is the lattice degeneration. The important thing that we need to know is that almost 30 to 40% of myopes will have it, and 30% of RDs are associated with lattice degeneration. So we cannot afford to miss these in our practice, whatever kind of practice we are in. So it's our indirect ophthalmoscopy with indentation is very important to identify these things. And a little assuring is that 2.8% of lattices cause RD. But still we need to understand, and 30% the cases that we see will have a underlying lattice degeneration. Another is a more benign form, which is the snail track degeneration. It is considered to be a precursor to lattice, which is a bit debatable. We have degenerative retinoschisis, zonular tufts, zonular tractional tufts. Retinal tears are quite obvious, and retinal holes are very obvious when you see them. A very important event that we need to know about is PVD, or posterior vitreous detachment. So it is the link that is between a predisposing lesion that we talked about and the ultimate thing, that is the retinal detachment. Now it can lead to tears where the vitreous is very firmly attached. We all know where it is well attached, and it gives an access to this liquefied vitreous through the retinal bakes, and thus leading to a retinal detachment. So 10 to 15% of the patients with symptomatic PVD will have retinal tears. So we have to have a very high suspicion of retinal tears in these cases. And whenever you see pigments in the vitreous or vitreous hemorrhage, there is a 70% risk, which is a very high risk of having tears. So you have to keep these patients under very close follow-up. Keep calling them until unless you are very confident that you have examined the periphery well in these cases. And a lot of times what we see is that we are seeing the periphery and the break is somewhere near the posterior pole also. So once I had missed a case, whereas I was very aggressively looking at the periphery but missed something which was very right there in the center. So there are certain studies. These studies I've just picked up for people who do refractive surgeries. And it's very relevant to cataract surgeries as well, because these degenerations, are very common in myopia, and we have to understand as the myopia progresses in patients, these degenerations also increase. And PVD is also more common in myopes and may present at a much younger age in these cases. The laser-based refractive surgeries, there are a lot of factors that induce such things which will lead to a RD. The high intraocular pressure that is there, a shock wave that comes during the laser ablation, and the rapid lowering of the IOP as well can lead to these are like mechanical stresses. Now, a lot of patients do complain of increase in floaters after LASIK, and even the newer surgeries like femto-LASIK may also, have PVD, increase the incidence of PVD due to various reasons. So, in both myopic patients, pre-op and post-operative, it's very important to screen them for these things, and lasers should be done when needed. So, about identification, as I said, indirect ophthalmoscopy is the mainstay when you come to diagnosis the diseases. So always refer to a retina surgeon, or I feel every ophthalmologist should be equipped to diagnose themselves as well. Now we have wide field imaging which can help us, but these are expensive right now. And so when to do a dilated exam, I think a flat answer would be always, but at least for the first visit of the patients and on an annual basis. It's must in these cases, of course, all myopics, one-eyed patients. When you see an RD in the other eye, a patient has a family history of retinal detachment. So history also is very important in these cases. Whenever we are planning a surgery, these trauma cases and sudden flashes and floaters, and of course vision loss and all those things are then we have to see. There's another nice paper where they have recommendations when it comes to these by Dr. Venkatesh Ramesh and IGO. We have to have these noted down and pasted somewhere in your OPD, which lasers should be considered and need urgent treatment. So a lattice degeneration with a hole. So whenever you see a lattice degeneration, just indent it properly and see all its edges to identify a hole if it's there. HST or a retinal dialysis definitely need a laser, and a presence of hole with a cuff of surrounding subretinal fluid, and when trauma leads to retinal breaks. So these are very important considerations which have to be lasers. There's no two-way about it. There are certain lesions where we can debate whether you want to laser or not. So if there is a predisposing lesions, which we talked about earlier, with recent onset of flashes or floaters, when they are both associated together, patients undergoing any surgery or even an injection or a YAG laser, they should be lasered. History of detachment in other eye with a predisposing lesion, or I go for lasers in even benign lesions also. One-eyed patients and certain syndromic patients such as Marfan's or Stickler should also be considered for lasers. As we said before, family history of retinal detachment, if the patient is unable to visit you for certain reasons on a regular basis, and at times in mentally challenged patients, we also be a bit liberal when it comes to lasering. These cases we can safely observe a patient with a lattice who has no symptoms in terms of flashes, floaters, black dots. Lattices with no breaks or holes you can afford to observe, but keep them in follow-up. A pigmented lattice with no break is pretty safe usually, and lattice with atrophic holes are also safe, but should be observed. So the key word is we may not laser, but we need to observe them very clearly. In the same article they had mentioned about how the screening protocol should be in refractive surgeries. It can be extrapolated to other surgeries as well. So if a patient is scheduled for surgery, you should do a retinal examination. preferably by a retina specialist, or if you feel you are well trained to see the aura, and or if you have a wide field imaging system which you rely on, that can also be done. And if you note a lesion which requires some management, then you should treat the lesion and follow the patient for at least 14 days, for 2 weeks, and then plan the surgery. So I went through a lot of literature. That is the most common consensus, that at least 2 weeks you should wait for these cases. Do the surgery, re-examine after 2 weeks, and after that things should be stable. But if patient complains of any other complaints, then you can keep the patient on follow-up. So just quickly, as my time is over, I will talk about the laser as such. So the laser helps. It is proven. There is no doubt about it. The incidence decreases from 43% to 13%. The mechanism is it generates stiff chorioretinal adhesions surrounding this lattice, and it's like a barrage. It prevents anything else from happening. We have two popular modes of delivery, that is slit lamp and the laser indirect, and both have their pros and minuses. I now do most of my lasers, even barrage, with slit lamps. It's more ergonomically and better for the back as well. Patient, I feel, is also comfortable, but there are certain cases, like a patient has undergone recent surgery or a child under sedation, then LIO would be more preferable. So the laser settings is 200 to 500 microns with power of 100 to 200 milliwatts and a duration of 50 to 300 seconds. And these you can titrate as you go on. You have your own settings in these cases. So at least 2 to 3 burns, not too wide, are recommended for this. Very important to cover the anterior margin. If not, you can try to barrage it till the aura. And indentation, always, if you find it difficult to visualize, it becomes very useful. And or you can use cryo anytime. So it should be moderately wide as shown in the image. And too intense lasers will will lead to hemorrhages. There might be traction, which cause more problems. It is more painful, can lead to things like ARM, and at times we've seen CNVM also. And whenever you burn, there is a more you burn it more, then treat that as a separate lesion and laser it out. So follow-ups, as I said, at least one follow-up after 2 weeks, and then you should keep the patient on regular follow-up. Just to conclude, dilated examination is a must. I don't think so that's a concern now in today's world. It's very important to know what are the predisposing lesions and to identify them and follow them up. Document these and counsel the patient well. If you have a ultra-wide field imaging, your job becomes easier. But if a patient comes with no complaint, it's very difficult to counsel them for a laser. A lot of times my patients who are educated ones want to see these weak areas which we are unable to show them if we don't have a wide field imaging system. So prompt treatment and follow-up. And I feel whenever you are in doubt, treat it, and do not hesitate to refer the patient to a retina specialist when these cases are there. Thank you so much.
Thank you, Dr. Divya. And in this context, I would just like to mention that Professor H.K. Tiwari used to say that if you have laser, you must do it. If you don't know, you follow. You don't have the laser photocoagulation, simply follow these patients. Many of the lattice with holes without any symptoms, they used to say that you continue following.
Right.
So, but the things have changed now, because in the world of Consumer Protection Act, if you don't do laser photocoagulation, and by the way, if it happens, I mean, in 2% cases you get detachment, then you are in trouble. So thank you so much, Dr. Divya. Divya is practicing at Lucknow.
So as you said, informing the patient is very important,
Yeah.
so that at least they know that if they don't get it done, that's
Sometimes
there.
iatrogenic laser can also give a
Yeah.
direct
Yeah,
work,
that is
yes.
also there.
Yes. I've seen one of the fellow who did the fellowship from Nagpur. He did the first very case. He said that myopics are the left myopics are the best case for doing the lasers. He did one very case, not laser, the cryo, and patient landed into full-fledged detachment. Improper cryo, or cryo itself can lead to it. And he left the vitreoretinal surgery. He is now anterior segment surgeon.
I think that was a good decision.
I am facing a Consumer Protection Act because I did laser. I could see the hole. I did laser. It was a big hole, and then I referred him to Lucknow for the detachment surgery, but he didn't go. It went there after 3-4 months, and by that time the problems were. So he has sued me. किया, आपने लेज़र किया इसलिए डिटैचमेंट हो गया. So these things are there. We must get a good consent in all retinal
Good
cases.
consent and proper documentation.
Now may I request Dr. Jivtesh Singh, who is practicing at Ludhiana. He is Damad, son-in-law ji of Dr. Shrikant and husband of Anushri. So Dr. Jivtesh, please.
Very good morning to all. My topic is techniques of pan-retinal and scatter photocoagulation. So just brushing up on the indications of pan-retinal laser. First is proliferative diabetic retinopathy, neovascularization secondary to CRVO, retinopathy of prematurity, Coates disease and Eales disease, as sir was talking, the incidence has come down now, familial exudative vitreoretinopathy or ocular ischemic syndrome. So just brushing up on how does PRP works. Once you give the laser burns, it causes vessel shrinkage, and the retinal burns itself destroy locally the retinal tissue, which leads to reduced oxygen demand and further reduction in VEGF. The VEGF levels decreases. So ultimately the complications from VEGF, that is vitreous hemorrhage and neovascularization, they also decrease. So as discussed by previous speakers, there are two modes of laser delivery. One is slit lamp, which is ergonomically better both for the patient and for the doctor. And one is LIO for the more peripheral lesions. So as previously the speakers were discussing, there are two types of laser. One is single spot and one is multi-spot, that is Pascal. Single spot laser can be done when you have like maybe a lower patient load or when you have one or two patients. So that takes slightly more time. The Pascal laser, you are able to give up to 16 or multiples of 4 spots. So you can do the same patient in 1/3 of the time. And they're more, these Pascal lesions are more well spaced. I'll show you them in the further slides. So a technique for doing a laser is we put topical drops, put a coupling agent in the form of either a visco or like any gel. You adjust the magnification brightness and set the laser parameters. I'll show you the laser parameters now. So these are the common laser parameters. The power is mostly from 200 to 800 milliwatt depending on the media clarity, depending on the patient's lens status, if he has a cataract or if he's pseudophakic or clear lens. Spot size is usually kept to 200 to 500 microns. Exposure time is here it is in 20 milliseconds. It is actually 100 to like 50 to 100 or 200 milliseconds. So this is the most common lens which we use to do, which we use in PRP laser. It has a magnification of 0.51 and it gives a very good field of 165 degrees. So you are able to see almost most of the retina in real time. So you can manage your laser delivery better. So these are other two PRP lenses which are less commonly used, but most common use is this Mainstar PRP. So this would be the most important slide. Here, as we can see, the first usually PRP is completed in 3 sittings. So the first sitting should be done in the inferior most part of the retina. Reason being, if anything bleeds from a neovascularization vessel, with gravity it will settle down. So it will not hinder you from doing further PRP sittings, which is superiorly or nasally or temporally. Second sitting you can either do on the nasal and temporal sides and superiorly. So I was talking about the Pascal laser, the pattern scanning laser. So this is basically a semi-automatic pattern laser, because here you can control where to do, and the laser points are also well spaced. So I'll show you one, so this is LIO as we discussed for the more peripheral lesions. So I will show you one small video. This is basically a laser simulator which is available on the website of American Ophthalmological Society. So I pre-recorded a video. I hope the voiceover is there. One second. How to start either a pattern. Can you increase the volume? Or a single spot laser. Can you increase the volume? First of all, we'll decide the parameters. The power you should start the laser should be approximately 200. We need the minimum power which gives you a gray spot. Also check the status of the laser, if it is ready or it's on standby. You should put the status to ready. Spot diameter is 200 microns. Exposure time can be 10 seconds or 20 Exposure time milliseconds. is approximately Depending on whether you are 100 able millisecond. to achieve So that perfect this is gray one color. correction which needs to be made It here. should not be too white and should not be too faint. One method. Single spot laser, as we have decided. Here the power is not sufficient, so we'll increase the power.
Basically, we need a dirty white gray burns. These are the adequate burns. We don't need very intense burns.
Dirty white.
I mean,
ये तो
gray.
मैं off white ठीक है.
Gray color burns.
So you can see the
dirty.
single spots which are coming. In PRP, for a diabetic retinopathy, we initially start with the inferior retina. So I'm shifting to pattern scanning laser now. So this is the pattern which we have decided. So the spot size is 200 microns, exposure time is 20 millisecond.
So basically, you need
So
to
in
stay
pattern
clear of
scanning,
the
you
major
can
blood
give
vessels
more equidistant and well spaced laser
and start with
marks.
the inferior retina in the first sitting.
So once the inferior retina is complete in the second sitting, you
Second
go
sitting
to
can
the
be done either
temporal and nasal
nasally,
retina.
temporally, or superiorly.
Try to leave the area inside the arcade not exposed to laser. So in the second sitting, once temporal and nasal area is completed,
Ideally, we should stay
you
away
go to
from
the superior
major
retina.
blood vessels and 2 disc diameter away from the optic disc as
you
well.
can see the pattern scanning laser.
So
saves you
Pascal
time,
laser will save
gives
you
more
time if your
equidistant
workload
spots
is more.
as compared to the single spot laser.
That's it. Thank you.
Thank you, doctor.
Thank you, Dr. Jivtesh. Thank you, sir. May we have a photograph of all the faculty? Dr. Kundlu is there.
उससे पूछो कहाँ आगे खड़ा होते हैं.